Well, good afternoon, everybody. You don't see me on camera, but this is Stacy Porter with the Policy Center for Maternal Mental Health, and I am here today with Bertie Meyer from PSI, who is going to be our lovely instructor. And you are all on, as you registered for our Perinatal Mental Health 101. It's just a overview course. Before Bertie gets started, I'm just going to remind everybody that we do not distribute the slides from today's webinar. We also do not provide certificates of attendance. There's no CEs for this. It's just a complimentary training, but all of our registrants will get a follow-up email that has the link to this recording and also a link to the resources that Bertie's going to talk about. So you will get those things from today. Bertie, welcome. I'm going to turn it over to you to introduce yourself and we'll get started.
Stacy. Thank you, Stacy. Um, Stacy and I just saw each other in Washington, D.C. at the Policy Center's forum. When was that? In March, wasn't it?
Good, yeah.
We were just together. It's been a little while. It's kind of fun to see each other in person. So, hello, everyone. Yes, I am Bertie Gunyon-Meyer. Stacy is going to leave the chat open for a minute. I want to see you all start. Put in the chat, where are you from? Just say, where are you from? I want to see what state you're from and
Yeah.
what you do. That's fine.
And
Indiana,
Bertie's going to pull up her slides
Indiana,
here.
I saw a
Sure.
couple. That's where I'm from. Look how many. Valparaiso, Indiana. Sorry, I'm calling out Indiana. That's where I'm from. I think I saw Nashville, Indiana. Is that possible? It could have been Nashville, Tennessee. IN and TN look the same sometimes. You're from all over. Isn't this exciting? I'm seeing all the states. Yeah. Oh, Denmark. Somebody's here from Denmark, UK. Canada's in the house. That's hello. Cincinnati, Ohio. I'm sitting in Columbus, Ohio right now, Cincinnati. How about that? You could have been here with me in Columbus. Questions will be answered at the end. Somebody asked. If you have questions, you're going to put them in the Q&A here in a minute after I've had a good time seeing where you're all from. Then I will close this up and you will only be able to ask questions in the Q&A. And I'll ask Stacy right now to go ahead and close the chat. Thank you, everyone, for telling me where you're from. Just an overview, because the rest of you now just got cut off. So let me share my PowerPoint and let's get going, because it is oh, for Pete's sake, I didn't even get to hit the stop the share, start the share. So I'm Bertie Gunyon-Meyer. I'm a nurse. I also have a master's in psychology and counseling, so I'm also a psychotherapist. I worked at a hospital system in Indianapolis, Indiana, the entire state of Indiana, for a lot of years. Indiana University Health. In 1997, I opened and started and founded a perinatal mood disorder program at Indiana University Health and taught all 15 hospitals statewide all about perinatal mood disorders after I learned, because I didn't know anything in 1997. So I went on to set up a screening program and all of that. But we do have 15 hospitals statewide. I continue to teach a fourth trimester class for IU Health. But I did retire from IU Health in 2018, and I work full time now for Postpartum Support International. I have been a volunteer starting in 2000 with PSI, and they are the largest organization with resources and education for perinatal mood and anxiety disorders. And we team up with the Policy Center, who Stacy's from, and Joy Burkhart is usually with us, but she is on a well-deserved vacation, and so she isn't here. I'll show you her picture if you are not familiar with Joy. That's me and Joy meeting up somewhere along the way. I think we were, I don't know, I think we were in California, but who knows? So that's me. I'm also trained in lactation. I was a childbirth educator. I'm trained in perinatal bereavement. I am a past president, and I set up the first and only certification in perinatal mental health, which now has a different director because I now am the education and training director only and not also certification, which I'm happy about. I am on the Maternal Mortality Review Committee for the state of Indiana. So, welcome to all my fellow Hoosiers. And how about go Pacers? Our Pacers just keep winning. We're pretty proud, okay? We are pretty proud. So, I just want you all to know this is a 90-minute, very quick. This is to whet your appetite and for you to say, I want to take more training. Oh my gosh, I did not know these things. I did not know this was all offered. So I'm going to run through 90 minutes of an overview of perinatal mood disorders, signs and symptoms, risk factors, a tiny bit about a few other things, screening, breastfeeding, but mostly you need to know that if 1 in 5 to 7 women uh, yeah, 1 in 5 to 7 women get a perinatal mood disorder, 1 in 10 men. I know this could bring up feelings for this audience. And so just check yourself. If you need to walk away, you're going to get a recording tomorrow. So some of you are here, some over 400 of you are here with me. We've got over 1,000 people who signed up. Some of you are listening to this later in recorded time. You will all get a recording tomorrow from Stacy. And like she said, there are no CEs, no CMEs. There are no handouts other than you will get a handout along with the recording of just resources. So think when you're seeing this, just resources. So it's the vision of PSI that every woman and family worldwide would have access to information, social support, and informed professional care to deal with mental health issues related to childbearing. PSI promotes this vision through advocacy and collaboration and by educating and training the professional community and the public. I let's acknowledge. I'm not seeing any of you, but we're going to acknowledge diversity in the room. We're going to be respectful of all voices, opinions, and experiences. Mainly like to point out, honor the differences of how parenthood and family are defined. And we recognize that most research done up until about 5 or 10 years ago was done on white heterosexual couples. I use inclusive language the best I can, but you're still going to hear me say mama and daddy and dad and mom and mothers because some of the research is done on moms. And I'm not going to say moms and birthing people if the research did not use other than females. Okay, mom. That is what most of our research. So I just want to make sure when I want to be true to research. Um, what do we need? What do childbearing people need? They need a companion and advocate to provide support during pregnancy, birth, and the first year postpartum. Who gets that? People who have a doula. That's who gets that. Some people might have that with their OB care provider. You just don't know. We need supportive professionals who are knowledgeable about a mental health and will help them access help when they need it. We don't have that with everyone, do we? And that's why you're all here, because you're going to spread the word. More people need educated. Having a time and a place to talk about your continued pregnancy, birth, and that continuing postpartum experience. So why do we care about this? It's the number one medical complication related to childbearing. When we don't treat, American College of Obstetrics and Gynecology says here's their consensus bundle is, and we just know this, when we're not treating a perinatal mood disorder, you're going to have poor adherence to medical care, relationship problems, exacerbation of other medical issues, interpersonal violence, separation, divorce, loss of finances, financial trouble, disability, unemployment, child neglect, abuse, developmental delays, behavioral problems, more nicotine, more smoking weed, more drug use, more alcohol use because of self medicating, and the worst of all, infanticide, homicide, suicide, because we aren't getting treatment, we aren't recognizing and getting help. So this is the report that came out in, I think, about 2021. I need to update these because I know we have a new one, but it's going to be about the same. And that is that We put together 36 different states' maternal mortality review committee results. So I'm on the maternal mortality review committee for Indiana, like I said. We look at all deaths during pregnancy and in the first year postpartum, and we look at what was the cause. Was it preventable? Was it due to racism? Was it due to mental health issues? Was it due to substance use disorder? We just look at every single case. So all the states do this. So this was just a consultation from 36 states, and what we find, what I have been telling people for years, that the number one reason for maternal mortality is mental health conditions. I'm telling you, for years, people came back from conferences, including me, and what did we hear about? Physical, preeclampsia, hemorrhage, cardiomyopathy. All these things are very important, and they are part of maternal mortality, preventable things that we can look at. But we never mentioned this, as if this head is not attached to this body. We just only talked about physical. And in fact, we still kind of have this mentality that says we'll treat your physical ailments during your pregnancy and during breastfeeding and postpartum, but no, I don't want to talk about using medications for here. Now, I wouldn't take you off your blood pressure medicine, would I? No. Would I take you off your insulin? No. But every day, somewhere, somebody's getting taken off their antidepressant, aren't they? Yes. We want to be safe. We want to be natural during this pregnancy. Well, as one of my 18-year-old clients said, she didn't want to take medication. And I was just asking her to put a foreign substance in her body. And I said, "You just told me you smoked weed." And she said, "Yes, but that's natural and from the earth." We kind of just get this mentality, don't we? We could have a whole discussion about cannabis, but we aren't going to do that today. I just saw a new paper came out, by the way, on that, but we can read all we want. Here's what we found for the reasons for maternal mortality. So this just breaks it down a little more. Cardiac coronary conditions in Black persons, mental health conditions, the leading cause in Hispanic and white persons, and hemorrhage leading cause in non-Hispanic Asian persons. Big takeaway, 85% of these pregnancies related deaths were preventable. At the end of every case we look at, was this preventable? What could have been done? Was this due to racism? We go through the whole thing. And like I said, to find out that it's due to mental health and substance use disorder, that is the number one reason right there. Those two together, substance use disorder and mental health conditions. Sometimes substance use is an overdose, accidental, sometimes on purpose. Sometimes we can't tell. So we find only half of them. And then how many get treatment? Hardly anyone. Look how few go on to get treatment. Why is that? Because we hand them a card. Here, call Bertie. Well, what if I have phone anxiety? What if I have anxiety? What if I'm depressed? I don't follow through. What if you give me a 10-page piece of paper with 25 different names on it of people who take my insurance? Here, give these people a call. They take your insurance. The first three places I call, they don't have openings. They're not taking any new patients. What happens? I quit looking. I quit calling, or I don't call at all. This will go away. I'll just wait. It's just so embarrassing. We've got to follow through. We've got to help them find the resources. Plus, we have to know where the resources are. So we call it perinatal mood and anxiety disorders. It's a big, broad umbrella term for that narrow definition that most of us know, which is postpartum depression. But please still call it postpartum depression. If someone asks what I do for a living, I don't say that I work in the field of perinatal mood and anxiety disorders. I don't, because no one knows what that means. And they would say, "What?" I say I work in the field of postpartum depression, and everyone says, "Oh, that's a real thing, isn't it?" Yeah, it is. So that is what I say. And if someone's Googling, what are they going to Google? If they're Googling for help, postpartum depression. So use it with your clients. They're still going to use it. You might hear the term perinatal mental health, like this is called Perinatal Mental Health 101. That's nice, universal term. Or you might hear perinatal mental health disorders. Sorry, allergies. So 80% of us get the blues. 1 in 5 to 7 mothers experience serious depression or anxiety. 1 in 10, 1 to 2 out of 1,000 will develop psychosis, and 1 in 10 fathers. Sorry, guys. Stacy always says you got your water, and I didn't put it next to me, but I've got one close by. Oh, I do have a drink right here, Stacy. I'm good. 1 in 10 fathers. I'm in a hotel room, so I'm not in my usual. I'm giving a 3-day conference right now in Columbus, Ohio. And so I'm up in my hotel room with my background blurred. Um, so you don't see my hotel room. Actually, I don't think you'd see anything anyway, just the back wall there. 1 in 7 women, 1 in 10 men from American College of Obstetrics and Gynecology, because that's our standard numbers. Um, Perinatal mood disorders can impact anyone, no matter how much money you have, no matter how many resources you have. Serena Williams said, not only was I accepting some tough personal stuff, but I was just in a funk. Mostly, I felt like I was not a good mom. I love that our celebrities are all coming out and telling their stories because then um, people say, oh, if she could have it, or if they could have it, then I'm not so uncommon. Alanis Morissette had us at every one of her concerts, I think 2 years ago, 3 years ago. And we had a table at every single concert passing out information on Postpartum Support International and on perinatal mood disorders. And up on the big screen between sets, she was advertising perinatal mood and anxiety disorders and postpartum support international because she had a perinatal mood disorder. And if you want to hear a great interview, by the way, with Alanis Morissette about her own perinatal struggles, perinatal mood disorder struggles, she's interviewed by Dr. Kat Kayeni and Dr. Wendy Davis on a podcast called, now listen, I'm going to say it slowly, Mom and Mind. Mom and Mind. Mom and Mind is a great podcast by Dr. Katayun Kayani, and psychologist, and she and our CEO president, Wendy Davis, interview Alanis Morissette. So there you go for a nice little tidbit and a podcast for the day. It's only when we say the word postpartum depression, the problem is it means it's only in the postpartum period and it's only depression. It means I don't love my baby. I want to kill my baby. It's all about crying. Andrea Yates drowned her 5 children in 2001 in Houston, Texas. And the media, when something like that happens, and other horrible things since then, they will say they think it was postpartum depression, postpartum depression. It's all over the media. Well, Andrea Yates was psychosis. And many, when we hear those horrific stories like that, it's psychosis. So then people come to see me and say, Bertie, I don't have the kind of postpartum depression where you want to kill your baby. I know. Now, not everyone falls madly in love with their baby right away. Can we remember that? Not everybody does. And we don't put that on Facebook. We don't put that on social media. We don't say, hey, you all told me I was going to fall madly in love with my baby. Well, I didn't. I don't feel it. I mean, I love her. She's my baby, but I'm not in love with her like you said I would be. No, you don't put that out there because everybody'd be at your front door, knocking on your door. You okay? What's wrong with you? Except for the ones who didn't fall madly in love either. They'll grow on you in time. So you have to reassure, we want to make sure they're taking care of the baby, but not everybody falls badly in love. And when we just throw it out there, what's postpartum depression to a room full of lay people? They're going to say, what's that? We'll say, what's that mean? It means you want to harm your baby. It means you don't love your baby. It means crying all the time. Because what have we taught for years? Seriously, and some people are still teaching it. If you find yourself crying a lot, be sure and call your doctor. Well, what if I wake up mean, angry, irritable, rageful, screaming at my toddler, screaming at my spouse? You didn't tell me to watch for that, did you? What if I wake up anxious, jumping out of my skin, can't eat, can't sleep? You didn't tell me that. I'm not crying. I'm anxious. I'm irritable. You didn't tell me to watch for that. That's the problem. We're not even doing good teaching when we do teach. So you're going to learn that today. You'll hear teaching tidbits from Bertie today. When we say postpartum depression, it means it's only depression and it only happens in the postpartum period. So, in other words, hey, everybody's glowing and happy during pregnancy, right? No, not everybody. And we already talked about the physical versus mental, and that our head's not attached to our body. It really is. And if you haven't noticed, people just use the term postpartum now for the term postpartum depression. Let me give you an example. I hope I don't get postpartum. My sister got postpartum real bad. You get it? That's what people are saying now. They mean postpartum depression, but they're just saying the word postpartum. Postpartum is a time period from the time the baby's born through the first year is the postpartum period. So when a news reporter say to me, Bertie, tell me the difference between postpartum and postpartum psychosis, they meant to ask me, tell me the difference between postpartum depression and postpartum psychosis. And I have to explain that the word postpartum does not mean postpartum depression, but that takes a little while. Okay. So when you hear someone say it, you know what they mean. They mean postpartum depression. So we have all these myths, right? That it's going to be really easy to get pregnant whenever I want to, or gosh, I heard it was really hard to get pregnant if you had polycystic ovarian syndrome. I was told I'd never get pregnant because I got endometriosis. You'll hear all these kinds of statements, or the people that think it's going to be easy, that they're going to decide to get pregnant when they want to. We have myths that every pregnancy is planned. It's not. 50% of pregnancies are unplanned. 50%. It'd be great if we could plan and say, should you stay on this medication? Should we switch you? Should we change to this one? Or should we only be on one medication? Doesn't matter. Let's plan. But 50% are unplanned. They find out they're pregnant. They freak out. They take themselves off all their meds. Their mom tells them to go off their meds. Their OB care provider tells them to go off their meds. Their psychiatrist tells them to go off their meds. Anyway, all of these things happen. We have myths about getting pregnant, how easy it's going to be, how fun it's going to be. We have myths about what labor and delivery is going to look like. In fact, the only thing you plan for is labor and delivery. You don't plan for 1 second beyond that. We have myths about how easy breastfeeding is going to go for everybody, that the baby's going to sleep all the time, and the perfectionists, and you know who you are, everything always in order, and suddenly the baby is here and things are not in order anymore, and your world that was always in order is no longer in order. This is my own highly intelligent daughter and son-in-law who are a perfect example of 50% of pregnancies are unplanned. They got pregnant at 3 months postpartum after their first. So my sweet grandbabies just turned 6 and 7, and both their birthdays are in May. We think we're going to be happy all the time. We have myths that this is going to draw us closer together as a couple. And we have all the media images. Everybody has skinny legs and a baby bump. And I didn't have skinny legs and a baby bump. I don't have skinny legs, never going to have skinny legs. And I had more than a baby bump. I was just big, big all over. But this is images. Lots of our images are out there of what we thought when our myths of pregnancy. We can't know these things are not all true. All pregnancies are not wanted. All don't end in a live baby. All don't mean love in the relationship. All don't mean a healthy baby. All don't mean fulfillment. So that's part of your intake of, was this a planned pregnancy? How long have you known this person that you're having a baby with? They might have just met him on Tinder, right? Last month. And they got pregnant. Now we're going to try to make this work. And yeah, we don't even know each other's favorite colors yet, do we? So, what's it look like to enter motherhood, parenthood right here, right? Isn't this the image you have? Yeah, I use my friends and family for pictures. Now, I didn't know that stock picture person, but I know most of all these other pictures I have. Um, this is the image we have of what it's going to be like with a new baby. This is the picture. You're smiling, baby's smiling back at you. Or with they're brand new, they're not smiling yet, but at least they're just glowing and glazing into your eyes and you're looking into their eyes. These are all pose pictures. Happy couples, happy families, happy without being coupled, but babies smiling. Babies aren't screaming in any of these pictures that we see, right? This is the images. We are so overwhelmed when we have a baby. We have to keep reminding in our lives we have seasons of giving and seasons of receiving. When we're in the season of being a new parent, you're in the season of receiving. You've given before, you're going to give again. Right now, you're supposed to let others help you receive. When I am pregnant, it's all about me. Honestly, when you are pregnant for the first time, and those of you who have children, you're nodding your heads throughout my lecture. Those who are planning on having children, we might scare you. And I'm really sorry about those who are really pregnant for the first time, or those who are planning. There's still lots of good things, right? But we are going to tell you the facts. And in my fourth trimester class, I have those sweet little pregnant people, some of them coupled, some of them not, with their partners, some without. And they're just smiling and planning and getting ready to have all their childbirth ed classes. And they do one with me to kind of say, okay, what could you get a perinatal mood disorder? And what's this really look like? And what's the emotional roller coaster of pregnancy and postpartum? But they're really just like not a clue about how much my life's about to change. When you are pregnant, your estrogen and progesterone are as high as they're ever going to go. And when you deliver, they crash down, and up come oxytocin and prolactin and bring in the love hormone and brings in the milk. And just kind of, all of that going on at the same time. Um, so the crashing of the hormones right at the moment of delivery is what causes baby blues. So remember that. We'll talk about that in a minute. You're going to prenatal classes. You're learning all about pushing and breathing and getting ready. And all you're talking about is decorating the nursery and what cartoon characters and what colors we going to paint the walls and what kind of furniture are we going to get and what's our theme going to be. Honestly, pushing and breathing is all. And I'm telling you, then this moment happens, right? Now the baby's here. What happens now? Now the focus is on the baby. Now the birthing person is now pushed out of the picture a little bit because now focus is on the baby forming an attachment. Partner is thrown even further out of the picture. Okay. Now it's all about baby, then the birthing person, then the non gestational person is more out of the picture, not paid attention to at all, hardly at all. You are fatigued, sleep deprived overnight. You lost all your freedom. You don't get a come and go as you please anymore. You lost all control of your schedule. Your schedule's your baby's schedule, and you don't have a clue what you're doing. Not a clue. And no matter how much I try to tell you that, when you're sitting in my fourth trimester class, I'm going to tell you you're going to lose all your freedom, all control of your schedule, and you're not going to know what you're doing. You somehow think you're going to have parents' intuition, mother's intuition. You are not. You just met that baby. You do not know what her cries mean. You do not know how to comfort her. This goes the same for if someone adopts a baby. Overnight, you lose all your freedom, all control of your schedule, and you don't have a clue what you're doing. And you're supposed to just know what to do. You don't. And no matter how much I said, listen to me, your life's about to change, but you don't just say it like, oh, your life's about to change, right? But the truth is that they don't even listen to me. Like we taught you how to change a diaper on a plastic doll in class. We didn't teach you that baby was going to poop up the back of their neck, right? Or pee in your face. No, the birth may not have gone as expected. You're learning all these new skills. You feel overwhelmed, huge role transition. You're now a mom, a dad, a parent, your parents together. This is a whole new role. You've never had this role before. So you're like adjusting to what? I'm the parent? I'm the parent. I'm supposed to know all the answers. You have all these dreams and expectations. You're facing fears and feelings, renegotiating who's doing the extra laundry, who's going to the store, who's dropping off at daycare, who's picking up at daycare, who's making meals, who's going to the grocery store, who's going to take off when the baby's sick or the children are sick, who's taking off work for the day. and nobody knows what they're doing, but you're all pretending you know what you're doing because they're all pretending they're knowing what they're doing on social media. Many of my clients get off social media because they say it looks like everyone else has it together but them. Be honest, none of us know what we're doing when we have our new baby. So, physically and emotionally healing from labor and delivery, learning feeding the baby, learning feeding cues. So, never thought about losses around the time of birth or having a baby. I told you freedom, control, self esteem, because you don't know what you're doing. You knew all your roles before. Now it's a new role identity, finances change, image of career, career potential, and your body image after carrying a pregnancy, your body changes. You have stretch marks. You may have, all of that changes. Um, it's not good of how mother you really are. It's how good of a mother you appear to be on Facebook. That's one of my favorite memes. So the meat of today that you want to learn is, what does a perinatal mood and anxiety disorder look like? It can look like depression, anxiety, panic, OCD, PTSD, psychosis, and bipolar. These disorders can affect us at any time in our lives, but there's a marked increase during pregnancy and postpartum, and they look different and feel different. So for instance, let's say you already had anxiety, you've got a history of anxiety. Now, what's the anxiety about? A brand new baby, a brand new fragile human being that you know nothing about and you don't know what you're doing. So, this is where we get our 1 in 5 to 7 women. This was a study of 10,000 women from Catherine Wisner, reproductive psychiatrist, and others. Did a study, and what they found was 21% in their study. So, what they found from this was when they did this study, 1 in 7 developed a perinatal mood disorder during pregnancy, 1 in 7 in the first 3 months postpartum. But when they carried that study out through the first year, 1 in 5 developed a perinatal mood disorder. So, what was their diagnosis? It's 68% of them had depression. What went right along with depression? Anxiety. Anxiety and depression are buddies. They like to hang out together. Many times the presenting factor you will see is anxiety. So when we're telling people, if you find yourself crying a lot, be sure and call, or if you get depressed, be sure and call, we've got to tell them about anxiety. We've got to, because this is going to be at least half the people you see, if not more, are going to be showing signs of anxiety, not depression. And because we use the word postpartum depression, that's what we all think it looks like. 22% of them were diagnosed with bipolar disorder, and 19% of them endorsed thoughts of harming themselves. So let's start right out with baby blues. Overall mood of baby blues is happiness. Okay. I just cry easily. I cry easily at some commercial. Baby Dove. Baby Dove commercial will make me cry. Any kind of something will make me cry. But my overall mood is happy. I've got hormonal changes, like I said earlier, estrogen and progesterone crashing down, oxytocin, prolactin coming up, everything floating around that 3 to 5 days, peaks after delivery. It's unrelated to psychiatric history, it's due to hormone changes. It's due to the hormone changes. And look here, teaching point. First teaching point, 1 in 5 to 7 women, 1 in 10 men get a perinatal mood disorder. Number one, you tell that. You didn't know how common it was because you thought it was all the 1 to 2 in 1,000 psychosis. So 1 in 5 to 7 women, 1 in 10 men. Teaching point. It's common. Or PSI motto, you're not alone. 1 in 5, 1 in 10. Second teaching point, baby blues only last 2 weeks. If you are beyond 2 weeks and you still don't feel like you, don't say if it's beyond 2 weeks and you're depressed. Don't say if you're beyond 2 weeks and you feel, if it's beyond 2 weeks and you don't feel like yourself, you're not bouncing back. Yeah, they're not bouncing back, they're adjusting to parenthood. But if it's beyond 2 weeks and you're still having more bad days than good days, this isn't just occasional crying, adjusting to parenthood. Something else is going on. Baby blues don't last 6 months. People come to see me and say, with my last baby, I had baby blues for 18 months. No, you didn't. No, you didn't. It only lasts 2 weeks. You had something else going on. But you don't want to say the word postpartum depression, and they don't want to say it because then they're thinking that means you want to harm your baby. So, baby blues last 2 weeks. So, use terms like if you're just not feeling like you think something's not right, and that's what they'll say. People don't wake up and say, I think I have postpartum depression. They wake up and say, I haven't been myself since a baby's been born. Something's not right. I'm overwhelmed. So let's look at depression. Just what we know it is: sadness, crying, unexplained physical complaints, headaches, stomach aches, nausea, vomiting, diarrhea, neck pain. Typically with depression, not always, but typically overeating, junk food, sugar, chocolate, um, oversleeping, still tired, still exhausted, never rested, poor concentration, cannot concentrate. Irritability and anger could go along with depression or anxiety, but be sure and make sure we're telling people eating disturbances, sleeping disturbances, irritability. Always throw in anxiety besides depression and throw in irritability and even use anger or rage. A sense of overeating, oversleeping, so sleeping, eating disturbances, and then hopeless and helpless. This is where I'm not alone. You're not alone. 1 in 5 to 7 women, 1 in 10 men. You're not to blame. We're going to look at risk factors later. And then with the proper treatment, you will be well. We have to give hope. And without hope, so hopelessness causes suicidal thoughts. So don't forget that. Suicidal thoughts come from a sense, I will never be myself again. As Karen Kleiman says, it's not just like its symptoms, it feels like who I am now. This is who I am now. I'm depressed. I'm anxious. I'm never going to be myself again. I can't even brush my teeth, take a shower. This is what you're going to see with depression, especially. They're taking care of baby barely. They can't take care of anything else. And honestly, not showering for days, not brushing their teeth, no interest, joy, or pleasure in their usual activities, don't care about anything. Anhedonia, apathy, bleh, don't care. They feel isolated or they want to isolate. They don't want to be around anyone because they'd have to fake that they're having a good time because they're not. They may not be madly in love with baby. And they will say things like, I'm so overwhelmed. I had no idea it was going to be this hard. If I'd known it was going to be this hard, I wouldn't have had a baby. And then you don't put that on social media either. Sense of worthlessness. Oh my gosh. I had no idea the guilt and shame I feel. I've got a healthy baby, a wonderful spouse, and a beautiful home. Why am I in your office, Bertie? This is so embarrassing. I'm ashamed. You have to take away the guilt. We're going to go along. Why does someone get it? Because of risk factors. So we looked at depression, typical depression, overeating, oversleeping. What's we got going on with anxiety? Agitated, can't sit still, excessively worrying about baby's health, about their own health. What if this? What if that? What if the baby's got this disease? What if I've got this disease? What if my spouse leaves me and I'm left all alone? I can't eat. The thought of food makes me sick. With anxiety, they're not hungry. They're losing 20, 30 pounds in 2 to 3 weeks. And everybody's like, oh, look at them, got their figure back. Nope. They've got anxiety. If they're losing weight rapidly, they're not eating. They're vomiting. They can't swallow. The thought of food makes them sick. Or they can't figure out how to eat. They just can't find time to eat. They're just overwhelmed. They cannot fall asleep. They cannot stay asleep. They cannot go back to sleep. Don't ask someone, are you sleeping when the baby sleeps? That's like asking, are you doing laundry when the baby does laundry? It's just that silly, really. Here's what we're going to ask. If your baby slept for 4 hours, would you be able to sleep? Someone who just has a baby that doesn't sleep a lot is going to say, oh, yeah, you give me 4 hours, I'm sleeping. Someone who's anxious, no, I still couldn't sleep. Tell me why not? I can't shut my mind off. I'm worrying. What if my baby stops breathing? I have to watch her. What if someone broke in my house and stole my baby? There's so much to do. There's laundry to do. There's dishes in the sink. It's lazy to go back to bed after the 6 a.m. feeding. I've just got things to do. I can't shut my mind off. Worry, 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 constantly worrying, racing thoughts, shortness of breath, heart palpitations. Then I might go into a full-blown panic attack. Panic attack will be described, and we'll talk about it here in a minute, but they will have a choking, smothering sensation they'll describe around their throat, around their neck. Their lips go numb, their face goes numb, their hands go numb. They might pass out. They might have chest pain. They end up in an emergency department thinking they're having a heart attack or something awful is wrong with them physically. Once I've had a panic attack, you panic about having another panic attack. And the three greatest fears, and the way you will hear a panic attack described: I thought I was dying. I thought I was going crazy. I thought I was losing control. That's exactly how you hear it. So we looked at depression, anxiety, panic. Now we're going to look at OCD. What do we mean when we say, you're so OCD? You know what we mean. People say that. You're so OCD. Means everything's all neat, everything's in order. Um, the typical classic OCD kind of symptoms are cleaning, checking, counting, ordering. So, cleaning, we think about someone who overcleans, everything's neat in order, wiping down counters, mopping floors, vacuuming, checking and rechecking. Is the house locked? Did I turn off the curling iron? Counting, things have to be in sixes or even numbers, or there's a counting things with some OCD. Um, Conditions. Ordering. I can't let you help me with the laundry. You know why? Because you don't fold the towels right. Now, listen, I like my towels folded a certain way before they're put in the linen closet. But if you offer to do my laundry, you can fold my towels however you want to. I don't care. I don't have to redo them, but I don't have OCD. I got other things, but I don't have OCD. If I can't let you, if I actually have a diagnosis of OCD, I can't let you clean. You don't clean right. I can't let you do the checking for me because I don't really believe you did it. I have to have things in a certain number, and I can't let you um, fold my towels. I can't let you help me because you don't do it right. I'd have to redo it anyway. So that's kind of classic OCD. And listen, we all have some of these routines we do. It's not the same. If you have a diagnosis of OCD, this really can be paralyzing and get in your way. These are people washing their hands so many times their hands are cracked and bleeding, having to do so many routines and things in a certain order that they're late every day because of all the things they have to do. And if something interrupts it, they have to start over again. So cleaning, checking, counting, ordering. The other way OCD can look along with this or by itself is intrusive thoughts. I clearly saw my daughter gray and dead under the water. I couldn't give her baths or take her swimming or put her anywhere near a body of water. What kind of mother thinks these things? My daughter would have been better off without me. These are intrusive, repetitive thoughts come out of the place in your brain that wants to protect your baby. It's taken and twisted and said, what's the worst that could happen? And then you have that thought. OCD intrusive thoughts are images, pictures, a movie playing in your head, a story you're telling, and this is with OCD. Again, 88% of new parents have intrusive thoughts. What if I drop the baby? What if the baby stopped breathing? Those are pretty common thoughts any new parent would have. But if someone has an actual diagnosis of OCD, they are being bombarded constantly with an intrusive thought. There are certain triggers that are very common to OCD with perinatal, with a new baby. So OCD, and then there's OCD is OCD, but with perinatal OCD, there are certain images and pictures. Now, someone could have already had OCD. They had all their cleaning, checking, counting, ordering, intrusive thoughts, but now intrusive thoughts are about a baby. Now the cleaning is about the baby. Now it's about changing the baby's clothes frequently. Nobody can touch your baby. In fact, none of us like someone to touch our baby. Don't touch someone's baby without asking, first of all, but people walk up and touch babies all the time. I don't like it, but if you have OCD, You can't wait to get away from them, get the clothes off your baby, and you feel your baby is contaminated. So lots of contamination fears. Um, so what do? They have the obsessions followed by compulsion. So I have the thought, what if, what if, what if, what if? Then I have the anxiety about that what if. Then I do some behavior to try to comfort, make that thought go away. I have temporary relief, starts all over again. Okay. I cannot keep reassuring you that isn't going to happen. You aren't going to do that. It doesn't help me. I am going to think it again. The next time I get to the top of the stairs, I'm still going to think, what if I fall down the stairs? What if I drop the baby? What if I throw the baby down the stairs? What if I see that in my mind's eye, an image, a movie playing? This is an intrusive thought. They are intrusive, repetitive thoughts of harm coming to baby or my doing harm to baby. I get caught up in that what if thinking. I have tremendous guilt and shame. Oh my gosh, why did I have that thought? What kind of mother has that thought? What kind of parent has that thought? I'm horrified by the thoughts. I can't get the images out of my head. I can't stop them from coming. They engage in behaviors, and both parents can have them. Either parent obviously could have OCD and could be having these thoughts haunting them. So, what are common thoughts? Here is a picture of many of them. What if I drown the baby? What if the baby drowns while I'm given a bath? And that's what Jen was seeing when she was bathing the baby. She's seeing images, pictures. I'm driving down the highway and now tailgaters are on the back of my car. I've now got a baby in the back seat. I never had a baby in the back seat. Now I'm thinking, well, get away from my car. You're going to run into my car. You're going to hit my car. I have to pull over the side of the road. So driving is triggers. A lot of people can't drive. They have panic attacks driving. They have too many intrusive thoughts. Um, Sharp objects, knives. They have to take their knives and scissors, lock them in a lockbox, put them in the back of the closet. They think that'll stop their thoughts when they're in the kitchen. Height, water, sharp objects, traffic, sexual thoughts. This does not mean these people are going to do these things. And if they tell these thoughts to the wrong person, they get turned over to Child Protective Services. They get sent to the psych facility to be checked out because they think they have psychosis. That's because they're not trained in intrusive thoughts and they're not trained in knowing the difference between intrusive thoughts and psychosis. These are what if thoughts. They are images and pictures of harm coming to baby or they're doing harm, and they're very vivid images. And if they tell them to the wrong person, that's why we want to send to people only who are trained. Common 41% of deliberate harm, contamination or big thoughts, accidental harm, ordering, arranging, religious checking. So I'm going to give you all an intrusive thought you've all had. You ready? You're driving down the highway. You're behind one of those trucks with the cars chained up on it. You see it? What's going to happen? You know what's going to happen. Are one of those cars coming off? No. All of them are coming off, right? Every one of those cars is coming off, every one, and they're all going to hit you head on, right? That is a common intrusive thought we've all had. We all have lots of traffic kind of thoughts, but if you have OCD, you really could have a panic disorder while driving. If you have OCD intrusive thoughts, um, again, 88% of new parents have what if. It's when you have a diagnosis of OCD, they really don't resolve. They just keep coming and they're vivid and they're horrifying. So the gold standard is exposure and response prevention. Please don't mess around with exposure and response prevention unless you've been well trained and well supervised and had a consultant for quite a while. This is not something you mess around with, and it's especially unique and different in the field of perinatal OCD. But these are great places to get training. Thoughts do not equal action. We must ask, and it's just ask like this. Sometimes new parents have scary or unusual thoughts. Are you having any scary or unusual thoughts? And they'll say, yeah, I keep thinking, what if my spouse left me and I'd have to raise this baby by myself? That is a scary thought, right? That's a scary thought that happens after, if you're coupled and you suddenly think, oh, what if my spouse left? What if something happened to my spouse? But if they say like this, I can't say it out loud, Bertie. I just can't. It's awful. It's just, oh, it's awful. I'll say that's called an intrusive thought. Let's talk about it. You can say it to me. Now, we don't let them say it out loud at support group, okay? Because if I have intrusive thoughts and you have intrusive thoughts and I start saying all mine out loud, then I'm going to give you all mine and you got enough of your own. So we just say you're allowed to say at group, I have intrusive thoughts, but you don't give exact. Now, you're one-on-one with me in an office. Tell me your thoughts. Tell me what your scary thoughts are. I want to hear them. What am I doing next? I'm going to figure out to tell you all right now. How do I know this is not psychosis? Parent does not want to harm the baby. The thought's obsessive in nature, and it's odd and frightening. Isn't always the surefire way. We can't do totally black and white here. Parent has taken steps to protect baby. They are not having delusions or hallucinations. They are in touch with reality. How do we know that? We ask more questions. So, how do we know it's not just an intrusive thought? They are having delusional beliefs, hallucinations. They're hearing things, smelling things, seeing things that aren't really there. So, what's a psychotic thought? Bertie, my baby's eyes were glowing last night and I thought he was demon possessed. And I said to my husband, take the baby. His eyes are glowing. I think he's demon possessed. And I don't think that's a normal thought. Bertie, that's not a normal thought, is it? She called me the next morning. That could have been awful. That's not a what if intrusive thoughts. That's not what if my baby is demon possessed. Nobody's thinking that, right? Nobody's thinking that without being out of touch with reality. That's not a what if intrusive thought. That's not what if I drop the baby. That's I see my baby's eyes glowing. I think he's demon possessed. So you cannot say in just totally black and white thinking, if they're afraid of their thoughts, then it is intrusive thoughts. If they're not afraid of their thoughts, then it's psychosis. No, someone with psychosis, my client who saw her baby's eyes glowing, said, "Oh, and it scared me." So you'll see that here when we talk about psychosis in a minute. Psychosis waxes and wanes. Plus, it also, they can be afraid of their thoughts. That's where you're asking, what are your thoughts? Not, are you afraid of your thoughts? Oh, well, then you're fine. That's intrusive thoughts. No, what are your thoughts? Tell me about your thoughts. And if they say their baby's eyes are glowing and they're demon possessed, then that's not an intrusive thought. Over 80% of our frontline practitioners give incorrect diagnosis when they hear someone tell them about their intrusive thoughts. And so many people have been sent to inpatient psychiatry and then get discharged later when someone finally figures out it's intrusive thoughts, or they have 911 called on them or CPS called on them. We have support groups for OCD. We have support groups for about everything I'm telling you about today. So don't think for a minute there aren't resources. I'll tell you at the end very quickly all of our resources, but there are support groups for almost everything you can think of in the field. So let's look at PTSD. PTSD around childbirth is in the eye of the beholder. Don't tell me that my birth wasn't traumatic. It's in my eyes whether it's traumatic. So, great article from 2004 by Cheryl Beck called It's in the Eye of the Beholder. Great article on childbirth, post traumatic stress disorder after childbirth. It's an event occurring during the labor and delivery process and involves actual or threatened serious injury to mother or infant, or the birthing person being stripped of her dignity. It can be either psychological or physical. These are potentially traumatic events, and these, don't assume. Some people might have these things happen and not have PTSD, but the latest stats are saying almost like 45% of people report something traumatic. Almost 1 in 2 births, something traumatic happening at their birth. Could have been something that you didn't think much about as the labor and delivery nurse, but it was traumatic to them. So these are things that could happen at labor and delivery. I find someone who's been pushing for hours, and then we say, listen, you're just not progressing, and I think it's a time to do a C-section. And they'll be like, let's do it. I'm so tired. They're disappointed they had a C-section, but they aren't traumatized. Like this isn't a PTSD as much as, oh my gosh, the baby's heart's dropping. Get the OR ready. We've got to get this baby out now. Everybody's yelling, screaming, going down the hallways. I thought I was going to die. I thought my baby was going to die. That's all I could hear in my head is these people yelling these things. That can be a PTSD. Traumatic vaginal birth. Um, Hyperemesis gravidarum. This is where you vomit all through pregnancy. And then suddenly at delivery, the baby's born, vomiting goes away. And everybody's like, oh, you're fine. Your baby's fine. Great. No, she has PTSD from her pregnancy of vomiting 24/7. And no one believed her. They all thought she just had morning sickness. No, it was awful. She had to be rehospitalized, getting fluids because she vomited so much. Long labor process, witnessing the partner could have PTSD, watching a postpartum hemorrhage, many different things. They end up with HELP syndrome, end up in intensive care, unconscious for 2 or 3 days. This can look so many different ways. Cheryl Beck, again, nurse researcher, did a study. What did she find were the themes of a traumatic birth? Four common themes. Perception that you didn't care about me. You abandoned me. You neglected me. You stripped me of my dignity. You didn't support me, reassure me. Um, People will describe I felt violated. I felt raped. They did things to my body without asking. Two, poor communication. You didn't tell me what was going on. I felt invisible. I kept asking questions. No one would answer me. I felt powerless. You betrayed my trust. I came to your hospital. I trusted you. I trusted the staff. You betrayed my trust. And number four theme, did you have to do all that to me? When it's all over, why did you have to do all that to me? And was it necessary? Don't forget, one, they will not show up for their 6 weeks checkup, possibly. They will change hospitals. They will change OBs. They're going to be angry. There could be PTSD in the partner who witnessed birth. There could be sexual dysfunction. Get them to a women's pelvic floor physical therapist after a traumatic vaginal birth. Elective C-sections in the future, having no more children. And if we don't deal with this traumatic event, every single year on the anniversary, they're getting ready to plan a birthday party and they flash back and have horrible flashbacks and nightmares of that. And they could have anxiety attack flashbacks for years if we don't. We want to get healing from this traumatic event. So 1 in 3 women have been sexually abused, and the body keeps the score. Some people have dissociated, don't remember their abuse. Some do remember their abuse. Again, we're sticking our hands inside of them. We are touching their breasts, all these things that happen when they come in for a delivery. And they could think about having former prior sexual abuse, 1 in 3 women, sexual abuse, and then they come in and have a traumatic birth. You've got trauma on top of trauma. Plus, just having a prior sexual abuse could cause another traumatic re traumatizing them at birth. It affects breastfeeding. If baby goes to NICU, would you just remember that both parents in the NICU have PTSD until proven otherwise? If baby's doing well, they're doing well. If baby crashes, they crash. Stillbirth, neonatal death, low gestational age, in there for months, not getting to be with them, not getting to take their baby home. Intrusive memories of that hospitalization. Here are great websites which you're going to get. For instance, this. You'll get this on your slides that you're going to get. You'll get the resources. You're going to get all the pictures of all of our support groups and other fun things. I know that you've all heard about maternal mortality. You couldn't miss it. We talked about it earlier. We have a maternal near miss closed Facebook group. That's someone who almost died or could still die from labor and delivery, say cardiomyopathy, had a heart attack, had a stroke. This is a group that is moderated by PSI. Racial disparities. I just want to have a few slides just to remind you. We should all know this. You should know where your state stands in the lineup. Indiana is not in a good place in the I think the top 15. I'm here in Ohio. I know they're in the top 10 of the worst of maternal mortality and infant mortality, much higher, way higher, as you can see in Black communities, followed by the indigenous AIAN, followed by Hispanic communities. So Black mothers 4 times more likely to die from maternity-related complications compared to white mothers. More maternal morbidity higher. Infant mortality, pregnancy-related deaths, all higher in Black community, followed by indigenous, followed by Hispanic. Just the same numbers I'm saying that we are still looking at, still working on. What's it due to? Racism, biological weathering, over and over and over, being subjected to racism in all places in their lives, and historical trauma to add to it. So 22% we found in the study of 10,000 women, bipolar disorder. Many suffer for years without proper diagnosis. We do recognize in the DSM that there can be a peripartum onset of bipolar disorder. Some people are diagnosed for the first time postpartum. Some already knew they had bipolar disorder. Some didn't know they had it, but they did have it. We do know that they come in after crashing, like they might have been up for a week, manic, cleaning their house, and then they come in and say, "Oh, I'm so depressed." And if you don't ask enough questions, then you think, "Oh, poor thing's really depressed," and you put them on an antidepressant. You throw them into mania because you weren't asking enough questions to find out that it was a bipolar disorder. 50% are first diagnosed in the postpartum period. They will relapse if untreated. It is really generally recommended to stay on medications throughout pregnancy and postpartum when you have bipolar disorder. Should definitely be followed very closely by a psychiatric care provider all through pregnancy and the first year postpartum. Bipolar 1 and bipolar 2. Bipolar 2, the highs aren't as high, the lows aren't as low. You're not going to catch it as easily, but you're going to still have the high risks. Not quite as high the risk of psychosis as bipolar 1, but you still got the high risk, especially untreated. We're going to have a high number of people with bipolar disorder that will develop psychosis, and that's why it's not recommended to go off meds, and it's very highly recommended to be seen during pregnancy and postpartum by psychiatric provider. We have groups for bipolar in everything, almost everything, also in Spanish. Psychosis. I pretended I was delighted in order not to make other people alarmed, but I was steadily getting worse and soon resented having to change and feed Elizabeth. A deep male voice started talking to me, coming to me at times I couldn't predict. He told me I was so bad at being a mom that Elizabeth would be better off if I were dead. The voice told me that Elizabeth was sent by the devil. Then, when I began about fantasize about hurting her, I knew it was time to seek help. Do you see just in that statement, waxing and waning? In the same statement, she's saying a deep male voice coming to talking to her at times she couldn't predict, told her she was a bad mom, told her Elizabeth be better off dead. A voice is telling her that in her head. And then the voice told her Elizabeth was sent by the devil. This isn't a what if intrusive thought. But then she began to fantasize about hurting her, knew it was time to seek help. Uh-oh, that's not. You see how you got to ask more questions. Are you hearing voices, seeing things that aren't there? So that's where anytime you're wondering, oh my gosh, I don't know if I have psychosis or if I have OCD, don't forget, HRSA, Maternal Mental Health Hotline, is answered by Postpartum Support International 365 24/7. You can call and ask questions anytime you're wondering, I'm not sure what I'm looking at. Someone just called me and I don't know. Give us a call, 365 24/7. I'll have those numbers for you in the resources. Andrea Yates, who we mentioned earlier, did drown her 5 children in 2001 in Houston due to postpartum psychosis. Valedictorian of her class, bipolar disorder. I don't know if she knew she had it. I know that She had recently been taken off her antipsychotic medication or mood stabilizer, which is a story you'll hear frequently. She had just been taken off her mood stabilizer. She had just been taken off her antipsychotic. And 2 weeks later, you hear this horrible story because they went into a state of psychosis. Almost always, they remember everything they did at the time, but it was with different eyes because they're not in touch with reality. They look back on it and say it seemed so real at the time. Andrea Yates was saving her children. It was the only way for them to be saved, was to be baptized in the water to go to heaven. And she called 911 on herself after she did it. So it makes no sense. And so George Parnham, her attorney, first she was convicted of murder, and then it was overturned in 2006, not guilty for reason of insanity. And George has helped us get together a training for attorneys, other attorneys, to help with um, yes, helping those going through this, because we don't give out attorneys through Postpartum Support International, but we do train attorneys. And we've got a great training that'll be coming out this year as we train attorneys and judges. 1 to 2 in 1,000 will develop psychosis out of 1,000 women, which 1 to 2 in 1,000 women will get deep vein thrombosis. Okay, so we can tell you about watching for deep vein thrombosis or clots. We can tell you about getting maybe 1 to 2 in 1,000 might get psychosis. Don't call it rare. Don't say it never happens. 1 to 2 in 1,000 might get clots. 1 to 2 in 1,000 might get psychosis. No, it's not as common as 1 in 5 to 7, but it happens. And the 1 to 2 in 1,000 is from live births. We're not even talking about those who had miscarriages, those who had a stillbirth, those who, so we don't have a lot of really recent great research on psychosis or on bipolar disorder. So that's why we're kind of just still, there's a higher chance of them harming themselves or their babies. And not everyone who has psychosis harms themselves or their babies or commits homicide. Okay. So don't think that every single person there, and they is treatment and they do get better. It takes longer. So right now, Mass General Hospital does lots of research on psychosis, and every single patient I've ever seen for psychosis, I have sent to Mass General Hospital. First baby, these are just risk factors for psychosis. It happens in the first 2 weeks, but it can happen in the first 6 months. So they're tangential, they are grandiose, on the same level of God and angels. So we've talked about bipolar. Make sure you'll get this resource, great resources on psychosis. There's Mass General Hospital. I told you about. Go watch Grand Rounds every single Wednesday at 2 o'clock Eastern. Grand Rounds are given for the whole world to watch from Mass General Hospital with Dr. Lee Cohen and Dr. Marlene Freeman, and they talk about bipolar and psychosis and medications and tough cases, and you'll learn a lot, and it's free. We have task force, we have psychosis coordinators, we have support groups, we have DVDs. Let's talk about dads. 1 in 10 dads. They look different. We have support groups. We have chat with an expert. They 10%, no matter where we do studies, they go to their man cave. They play video games. They come home later and later from work. They're irritable, angry. They miss their birthing partner. They miss sex. They feel left out. We have a 2-day dads training. Single mothers, even higher risk than 1 in 5. Black mothers, probably 1 in 3. And single fathers, higher mortality rate than even. So our single parents are struggling even worse. We don't have lots of resources in the queer community. We do know from studies and within the queer community that there is higher rates of perinatal mood disorders, higher rates of suicide, and higher incidence of not finding resources. It's a growing population, And again, look for research, not lots in the area, but there is out there, and we're going to find more and more that we're going to find probably that same as 1 in 10 dads, we're going to find 1 in 10 partners. And don't forget, the non gestational partner can have a perinatal mood disorder and the birthing person doesn't, or they can both have it. And then you got a mess on your hands with both. Now, who gets this and why? Okay, who gets it? Those who have a previous perinatal mood disorder, family history of perinatal mood disorders, or symptoms in pregnancy we didn't treat you. History of any of the things we just talked about: depression, anxiety, OCD, eating disorders, substance use disorder, OCD, suicide, psychosis, bipolar, all of that runs in families. None of you have a clean history. You all have some of these. So some of you have more risk factors than others, and therefore those who have lots of risk factors are going to develop a perinatal mood disorder. You were a moody teenager. You're really moody and irritable before periods. You're moody and irritable with birth control. Thyroid imbalance, endocrine disorders such as polycystic ovarian syndrome, PMDD, decreased fertility, fertility challenges, diabetes. These are risk factors, proven risk factors. Inadequate social support, interpersonal violence, financial stress, poverty, recent loss or move, even higher than 1 in 5, military families, teen parents, parents of multiple, single parents, Black and Indigenous families, and temperament of baby throws the best of us over the edge. Complications during pregnancy, birth, or breastfeeding. You were a teenager or you're in your 40s. These are risk factors. Seasonal affective disorder. We just lived through the winter. I'm okay again. I'll make it again until winter comes again. And then I'll get out my happy light. Perfectionism, we already talked about. Pain, lack of sleep, abruptly stopping breastfeeding will crash down good hormones. And if you already had depression and anxiety, it's shooting up your depression and anxiety worse. So don't tell someone to stop breastfeeding just because they have postpartum depression. You're only going to make them worse. But if they need help breastfeeding, please get them help. If they want to stop, bless them and let them stop. Previous losses of any kind, okay? Miscarriage, selective reduction, termination for medical reasons, elective abortion, history of childhood sexual abuse, culture shock, the unresolved grief or attachment with your mother. Your mother passed away. Your mother's in another country. Your mother abandoned you, neglected you, abused you. Your mother and you haven't spoken in 5 years. You and your mother argue all the time. Returning to work outside the home. That's quite a shock after your first. You used to come home and take a break and did what you wanted all evening. Now you come home and there's no rest until you have fed and bathed and got everybody in bed. And then you stay up too late watching TikTok, don't you? And then you do it all again the next day. Make sure you're ruling out other causes. There could be other things going on. And you find out, yeah, they had a hemorrhage, their hemoglobin's really low, and they're not making enough milk, and they're also extremely tired and depressed. But it could just be anemia, could be trauma, could be thyroid imbalance. This is a great handout that we have, and we are giving you a copy of this, and you'll find it on our website. It's an overview of everything I just said, what it all looks like. It shows signs and symptoms, it shows risk factors, and it also then says how we going to get better, right? So if 6 to 8% of us get gestational hypertension, 6 to 8% get diabetes, and 6% get preeclampsia, and we're screening every single pregnant person, and yet 21% get a perinatal mood disorder and we're not screening, what's wrong with that picture, right? Okay, so talk about screening. We know who to screen. Who are we screening? Pregnant and postpartum people, right? We know who our audience is. We know we should think ahead. In my 4th trimester class, I tell them, let's think ahead. Who's going to help you? Who's going to do these things? We have through PSI a postpartum planning class. Tell your pregnant people to come to our postpartum. It's free. They can prepare for pregnancy, or yes, they can prepare for postpartum. They can also learn about perinatal mood disorders. And then my 4th trimester class. Screening, you can't tell by looking. Why are we screening? Because there's a high prevalence rate, because we got an audience. We know who to screen. We know how to screen. But despite all of that, not everybody's doing it. AAP says they should be screening. ACOG says they should be screening. But then when you ask them, there's still only half of them doing it. We don't have the time. I don't know where to send them when I find them. I don't know what tools to use. But we know that when we screen, we find them. Now, listen, don't bother giving them the Edinburgh Postnatal Depression Scale, scoring it, putting your electronic medical record and walking out of the room, and you didn't educate them on it, you didn't talk to them about it, don't even bother. You wasted your time and their time. If you're not educating, you should be screening anytime we cross the path of a pregnant or postpartum person, and we should be educating. Baby blues last 2 weeks. This affects 1 in 5 to 7 women. Here's the symptoms. Here, 1 in 10 men. Here's what it looks like. Here's who gets it. Yes, you should be watching for it. Here's who you call. So here's the standard of screening for all our major in the US organizations. Here is PSI's recommendations, which is way more than any of the organizations think. We should be screening a lot more than we do. This is not a validated screening tool, but it is a tool that you should just pass out to everyone, and it gives them, they can look at them. I recommend hospitals to send this home with the new birthing postpartum person, because it tells, here's how I've been feeling, here's my risk factors, and then teach this in childbirth ed class also. Here's our helpline, here's our support groups, and then there's a psychiatric consult line where you prescribers can call your psychiatric PSI, psychiatric consult line, make an appointment. You're a prescriber, but you're not quite sure about your frontline prescriber, not sure what to order, not sure what to do with this case. One of our reproductive psychiatrists will give of their own time for free to meet with you. It takes about 24 hours. Some of our states have access lines. So you call your own access line, they can do it. So here's just a blown up version here, full page of that discussion tool. It comes in Spanish, English, it comes for loss, just changing wording. And we just came up with a discussion tool for postpartum psychosis. So look out. I don't even have a picture of it yet. So know that there's now a discussion tool to help you go over with someone what to look for. So you want to tell everyone that we're screening everyone. Don't make them think they just look bad for today and that's why we're screening. No, we screen everybody. Why do we screen everyone? Because this affects 1 in 5 to 7 women and 1 in 10 men. So the chances that you're going to get it are pretty high. You're sitting here. You could be the 1 in 5. You could be the 1 in 10. We screen everyone because this is so important and affects our lives if untreated. So please be as open and honest as possible. And the two main tools that are used, just going to go over this, is John Cox from Scotland, and he wrote the Edinburgh Postnatal Depression Scale. He's co-author. And then there's also the PHQ-9. Those are the two mostly used. The Edinburgh is, or you can say Edinburgh when you're here in the United States. The UK person just said, what? Yeah, here in the US, we say Edinburgh, I know. But, if you know John Cox or you're from Europe, you say Edinburgh because you know that's how it's pronounced. And this is where the tool was made, was, by John Cox. It's available in over 60 languages. It's free to copy as long as you put the co-authors at the bottom of the page, just like this. I've got this at the bottom of the page. I say who developed it. It's 10 questions. The last question is, the thought of harming myself has occurred to me. It says, tell us how you have felt in the last 7 days. This is not 7 days. How'd you feel 7 days after delivery? This is whenever I meet you, I'm handing this to you and say, tell me how you felt in the last 7 days. I could have met you at 6 months. How have you felt in the last 7 days? And then this is just severity ranges. It's common sense. The higher the score, the worse off I feel. The PHQ-9 is 10 items. And with this one, it correlates with the DSM-5 diagnosis. Again, to me, it's common sense. The higher my score, the worse off I feel. Also comes in lots of languages. Also can copy it all you want as long as you put the authors, co-authors on the paper. And this one is, how have you felt over the last 2 weeks? And these answers are a little different. Not at all, several days, more than half the days, or nearly every day. And then their suicide question is, thought I'd be better off dead or of hurting myself. That's a lot bolder than the thought of harming myself has occurred to me. It also comes in a 4 shortened version, and then both the PHQ and the EPDS come in shortened 2 question. But keep in mind, for the 2 question, they're validated. but they don't ask about suicide, and we're not avoiding the suicide question. There's also another scale that just came out. It's great. It didn't just come out. The PDSS by Cheryl Beck, who I've already mentioned twice now, is that she is developed this, and it was not in the public domain until just the last maybe 4 months. So it can now be used by anyone and copy it all you want. Prior to this, you had to buy it. So it's a great, we found we didn't use it at my hospital because you had to buy it. And of course, they weren't going to let me buy something. So we used the Edinburgh Postnatal Depression Scale um, at our discharge teaching before they went home. We had screened before they went home, and then we did teaching on perinatal mood disorders, and then send them home with the discussion tool. So there's Cheryl Beck and one of our own trainers, Peck Inman, together, and that's them. It comes in several languages. It's used after 2 weeks postpartum, so you got to know which tool you're using and how you're using it. Bipolar, there's the MDQ you can use for screening for bipolar disorder. Probably the most common one everybody knows. There's also the rapid mood screener, is one that I find a lot of my psychiatric friends use. Psychiatrists, psychiatric nurse practitioners are using the rapid mood screener. So also another one. Just as I said earlier, as our CEO president Wendy Davis says, it's only a piece of paper. It's all about education, treatment, and referral. And if you're not going to teach them anything, don't bother doing it. So suicide, make sure we're asking on those suicide questions. Tell me why you marked the thought of harming myself has occurred to me. Make sure you're following up. You might want to use the Columbia Suicide Scale. You might want to call someone else in because you're not comfortable, but don't be afraid. It could be you just go, could you tell me why you marked here the thought of harming myself has occurred to me? Tell me why you marked a number 2. And you know what they might say to you? I tried to overdose when I was 14, so I thought you'd want to know that. Oh, okay. Well, thanks. How you've done in the last 7 days, last couple weeks? I'm fine now. I just thought you want to know that. Okay. The thought of harming myself has occurred to me. I used to be a cutter. I was afraid I might start cutting again. Or they'll say, I was in a hurry to get out of here. I didn't read any of the questions and I just marked 1, 2, 1, 2, 1, 2. It's a less to do with those who on the screening scale for the PHQ-9, because that one is pretty clear. I'd be better off dead. So that one, you're really like have to not read it to mark that. So make sure that we're following up with those with suicide risk during pregnancy. We are not going to walk away from it. If you're not comfortable, make sure you know who you're going to call, where you're going to send them, where are we going to refer them to. Make sure it's not always 911. Your local's crisis team is the best. 911 is just not always working well, and they're not trained when they get there. Your local crisis team is going to be more trained, or get them to your local emergency department. You can call the MMH hotline to ask questions. What should I do? Okay, how do we get them better? We need medical evaluation and possibly medication. We need social support. We need mental health counseling, and they need new parent classes, and they need cribs, and they need, so just those basic things. We need all these things to get better. Make sure you know who you're sending to. Do they know? Who do you know to send to that is trained in perinatal mood disorders? Counseling, they're going to need it, but I'm telling you this, they're going to say right now, I'm glad I took meds, I'm glad I saw a therapist, but if I hadn't had my social support, I wouldn't have made it. That is, if you can't get them in right away for medication, you can't get them in right away for therapy, you can get them into our support groups every day of the week. Over 50 in English and over 25 in Spanish. And find where those new parent classes are. This is what we're going to do to get them better. So you are not alone. This affects 1 in 5 to 7 women, 1 in 10 men. You are not to blame. This was caused by risk factors. You didn't do something wrong. You're not weak. There's nothing wrong with you as a parent. And with the proper treatment, you will be well. Make sure we're looking at alternative complementary. If we're not treating them, it's affecting everyone. It's affecting their pregnancy. It's affecting their outcomes. Breastfeeding, I've already mentioned a little bit. I think the main thing I want to tell you is we've had studies for over 40 years on breastfeeding medications, pregnancy and medications, and we need to get up to date on what those research show, what that data shows. because it's out there and too many people still aren't up to date. Just don't have her quit quickly over a cold turkey, but over a 2 to 3 week period. But mainly what I said earlier, providing support, information, and encouragement. If they want to breastfeed, get them help. It's so important. That's what they want to do. If they want to stop, or they didn't want to breastfeed, then let them, bless them without guilt or judgment. So, resources that you're going to get about breastfeeding, where to find information on breastfeeding and medication, on pregnancy and medication, and then I'm running through professional support groups. These are Facebook groups. They're not PSI, they're just other people, but it's great things to get on. Other organizations. We have an app. Be sure and tell your clients about our app. These are things you can give your clients you didn't even know I was going to tell you about. Here's our helpline. They leave a message, someone volunteers to call them back and talk to them, reassure them, and gets them resources they need. They connect them with their local volunteer coordinators in their state. Here is the national HRSA, the National Mental Health Hotline from the government, from HRSA, that PSI answers 365, 24/7 by trained professional counselors. We have coordinators in every single state who will help each of you to find where the resources are in your own state, where your support groups are. We have specialized coordinators besides all the millions of support groups. In over 40 countries, we've got volunteers. Every state has a chapter. Get involved in your state chapter. Canada also has lots of local chapters and resources, but these are the US chapters. We give out scholarships from our chapters. We have a directory where you're going to find people only on our directory are only allowed to be on there only if they have a basic 2-day, 14-hour training in perinatal mood disorders. Here's our access lines throughout the United States. You can see quickly if it's your state's not green, you probably don't have an access line. If it's blue here, you're working on one, and the grays, you still don't have one. The Climb is a fundraiser. Here's all the different supports we have. Make sure you know. We have a peer mentor program. We have a closed Facebook group for moms, dads, and for loss. We have support groups for about everything you can imagine. A phone call chat with an expert for moms and dads. Smart Patients Forum. Providers. We have professional consultation groups for peers and for doulas and for prescribers, but you have to be a PSI member. And we have medical provider training. It's just a 4.5 hour training recorded or 6 hour in person. We have psychiatric consult line that prescribers can call and ask questions. We have a perinatal mental health alliance for people of color. We have the Blue Dot Project. Here's our legal program that we are teaching others, toolkits. We have posters, brochures, all these fun things, flyers I showed you earlier, English and Spanish, DVDs in both English and Spanish. We're on everything social media and in English and Spanish. Videos, we have a bookstore. We have all kinds of trainings. Make sure you're looking at all of our foundational trainings, advanced trainings. We have perinatal loss 2-day training, a dad's 2-day training. This 101 that you're looking at right now, we're going to meet in New Orleans for our annual conference in July. We also have a perinatal substance use disorder 101 that I don't have a slide on, but we have it. It's also quarterly between PSI and the Policy Center. So look for that, sign up for that. It's a 101, no CEs, CMEs, but we have a whole 1-day perinatal substance use training. Here's all of our benefits. Join us, and don't forget, you're not alone. You're not to blame. And with the proper treatment, you will be well. And Stacy, I finished with 2 minutes to go. And I hope there's not lots of questions because I have 2 minutes. I see 8 questions. Let me see if I can answer thing. Oh yeah. I I think I answered that when you're asking, is there a prevalence with same-sex male couple? We don't have many studies on it, so I can't answer that question, sadly. I know that there's probably way too much shame to come forward with that, but think about this. If overnight you lose all your freedom, all control of your schedule, and you don't know what you're doing, you got the same incidence of perinatal mood disorders with a same-sex male couple, same-sex female couple. any kind of queer couple. It's just that they're not coming forward because they're like, we chose this, we wanted to do this. Fatigue related to depression and fatigue from a newborn. Yeah, you've really got to come to more of our trainings, Corey, to look at obvious difference. We got whole slides on what's the difference between just being tired and a new parent and being actual depressed. First of all, we have the DSM is going to tell you actual signs and symptoms of depression. What causes psychosis? Number one, we assume it's bipolar until proven otherwise. Could be chemical imbalance, could definitely be lack of sleep. You go without sleep for a week and you can have psychosis. So that's our main kind of guesses right off the bat, and research shows. Is there evidence-based tool that can assess for psychosis? There really is not. There is only we now have our discussion tool of what to watch for and signs and symptoms in that, but there is no, you really, it is training to learn to assess for psychosis. And it's not something you know till you've seen it a lot. And it's something you're going to have your friends on call for you, people you know that know psychosis, that treat it, that are going to be there for you. You've got the hotline, maternal mental health hotline, 1-833-TLC Mama, 1-833-852 6262. You want to make sure that you are calling there and asking, because that is going to tell you. Um, okay, what did I just miss? Yes, to find. So the suicide hotline, the suicide lifeline is 988. Call, text, and yeah, I have that on a slide. If someone is calling about suicide to our perinatal mental health hotline, then we do a warm handoff to the suicide hotline. We do a warm handoff to domestic violence hotline for many things. So we work closely with 988. And I had that on a slide for 988. Everybody should know that at this point. What research and treatment recommendations do we have lasting beyond a year? Perinatal mood disorder shouldn't last beyond a year. With the proper treatment, you will be well. Perinatal psychosis takes sometimes up to a year to kind of get back to their baseline self, but it should not take more than a year. If you've got someone in the field that someone that sees them for that are trained in perinatal mood disorders, they should not last beyond a year. That's usually people that are not going for treatment or are getting treated by someone who doesn't know enough about a perinatal mood disorder to find out what's going to work or knows what works. Yeah, we all have. You could have lifelong depression, anxiety, but you learn coping skills. You learn what things make us better, and the same thing with all of it.
Thank you, Birdie.
Oh my
We
gosh, I'm talking
past
as
time.
fast as I can.
Yeah, oh, I know, I know. There's always so much content to get
I
through, and
know.
I see.
Anybody in Canada can come to any of our support groups. People on here from Denmark and the UK, anyone can go to our support groups. Support groups are free from anywhere.
Beautiful. So yeah,
Yeah.
check out PSI's website to figure out what support groups might be right for you. You can find all the resources there. Again, we will be sending out a link to the recording of this training, and also a link to the resources that Bertie talked about. So you will all get that to the email address that you registered for this webinar with. You'll have it pri- by early next week at the latest. So thank you all for joining us today, Birdie. Thank you. A pleasure as always to see you. I
As
love doing this, love doing this quarterly training with you. On behalf of the Policy Center for Maternal Mental Health, I will say good day to everybody. And if you're viewing the recording, hope you learned a lot, and check out some of these other trainings. And if you're wanting to go on and get your certification, please feel free to look at that and enjoy your day. Thank you for being here.
bye.